Hello, welcome and thank you for joining us today as we continue our IB Users Group webinar series. My name is Linda Herman and I'm the Client Relations Manager for Imaging Biometrics. Today's webinar is titled Gallium Maltolate, New Directions for Cancer Therapy, presented by Dr. Al Jazawi, Assistant Professor at the Medical College of Wisconsin. Dr. Al Jazawi will discuss gallium maltolate's promise in targeting various cancers, including brain tumors such as glioblastoma and pediatric high-grade gliomas. Before we begin, we're excited to share an update about our expanded access program for gallium maltolate. This program offers access for patients with recurring glioblastoma who may not meet eligibility criteria of clinical trials. In recent months, we have expanded the program's reach by activating several new clinical sites across the country. The EAP allows for gallium maltolate to be administered alone or in combination therapy. This option allows patients to prioritize quality of life as gallium has fewer reported side effects. The EAP reflects our dedication to advancing treatment options and offering hope to patients with limited alternatives. To support this effort, the Micella Foundation has generously contributed donations to help offset patient startup costs. For more details and information, please contact us at eap@imagingbiometrics.com. We have muted the microphones and ask that you use the Q&A feature to ask questions at the end of today's presentation. And with that, I would like to turn it over to Dr. Al Jazawi.
Thank you very much. I'm excited to talk about gallium maltolate, which is near and dear to my heart. We've made some really great discoveries, and I'll share some of those. Oops. There we go. I have nothing to disclose. And I want to start out by saying that this work would not have been possible without a really great team under the leadership of Dr. Kathleen Schmeinda. We have awesome people on both the clinical and preclinical side for truly innovating and translational efforts, and I'm so happy to be working with them. I also want to thank all the funding institutions, internal and external, that have provided support over the 2+ decades that we've been working with gallium maltolate and have brought us to this point, and hopefully, keep supporting us in the future. Also want to thank IB for inviting me to give this talk and provide so much administrative support too, and their efforts into getting gallium maltolate to the patients. I will provide a teeny tiny brief overview of our brain cancer and then the hallway science that is part of our research, some very exciting new data, and then the future directions where we hope to go. As many of you know, glioblastoma is really the most aggressive primary brain tumor. It has a very poor prognosis in the patients, and on recurrence, these tumors are refractory to treatment, and there's really no standard of care. This is even more important on the pediatric side, whereas high-grade gliomas do have some treatment options. They are still very limited because they are different molecular and biological entity than the adult glioblastomas. What works in GBM, such as temozolomide, barely works, if at all, in high-grade gliomas. Similarly, with atypical teratoid rhabdoid tumors, ATRT, the treatment options are severely limited, and I really want to highlight and stress that chemotherapy that works in adults does not work in pediatrics. The chemotherapeutics pediatric patients receive are highly toxic. They have to go to super high doses to have some effect. And they're often partnered with radiation therapy, which also has severe side effects. Most of them are long-term cognitive and developmental effects, but also in the long run, patients that survive to adulthood often also have develop secondary malignancies due to the radiation. So clearly there's a need for newer and better therapies, effective therapies, but that are also really safe. Again, there's no standard of care on recurrence, newly diagnosed GBMs and pediatric primary tumors. We usually aim for maximal safe resection, and then radiation with concurrent temozolomide, and then adjuvant temozolomide plus or minus tumor treating fields. This treatment regimen rarely works again on recurrence. There's usually a kitchen sink kind of approach to see what works and what doesn't work. But these tumors are inevitably fatal. In pediatrics, maximally safe resection is often not possible, particularly due to the tumor location. That's especially the case in ATRT. And sometimes chemotherapeutics are contraindicated, and that leaves radiation as kind of the backbone for everything. And keep that in mind, because later we will talk a little bit more about gallium maltolate and radiation therapy. This brings us to hallway science. So the Schmeinde lab works on developing imaging modalities, MRI-based imaging modalities to study tumors, understand tumor biology better, but also to monitor treatment better, and to find imaging biomarkers that might also be predictive of outcome, or who might respond better to specific therapeutics. Dr. Chris Shitamber, who used to be, before retirement, just down the hall from us, was studying iron and gallium maltolate for years, gallium compounds, first generation, but then also gallium maltolate, and how they could be potentially utilized in cancers. Now, he started working on looking at lymphoma especially, but one day, he was like, well, we have this new drug and we're seeing really great effects in culture. And Dr. Schmeinde was, well, we have this animal model of brain cancer. Do you think this might work? And the rest is history, as they say. So just a brief background about iron. Iron is very important for normal cellular function. It drives energy metabolism in the mitochondria. It's important for DNA synthesis and repair. And it also provides a multitude of other functions within the cell, such as oxidative reactions, and it's involved in proliferation and other oxidative reactions. We all know its importance in hemoglobin, obviously, and iron metabolism is highly regulated in normal cells by this import-export balance, import via transferrin receptors, because most iron is carried through the bloodstream bound to transferrin, and then export via variportin. So usually there is more export. The balance is geared towards more export versus import in normal cells, because we only want to keep as much ions on hand that are needed. We don't want to have iron get stored in excess of what is normally needed, because then that can cause toxicity in the cell. And this is all regulated by hepcidin. Oops. In cancer cells, what happens is, because cancer cells are highly active, they're metabolically active, but also to aggressively proliferate and infiltrate, they have a high energy need for iron. So this balance gets put on its head, so to speak. Import outweighs export at this point now, just to feed more iron to the cell and fuel all these processes. Now, this can be exploited. Sorry, my slides got a little out of order there. Because gallium is in the same row on the periodic table as iron, which means it shares with iron a number of characteristics, such as the size, the charge 3+, which means it can bind to transferrin just like iron would. It can enter the cell via transferrin receptors just like iron would. It could enter some of the cellular processes, but ultimately, because it is not iron, it cannot participate in those really important redox reactions. So they essentially shut those processes down. And what that means is that gallium essentially acts like an iron mimetic. It's essentially entering the cell like a Trojan horse. Now, once it's in the cell, like I said, it can enter some of these processes, but because it's not iron, it will shut them down, which means, most importantly for us, it inhibits ribonucleotide reductase, which is crucial for DNA synthesis and repair. And also in the mitochondria, it shuts down mitochondrial complex 1, for example, meaning that we have no energy production. And this is just really two of the different mechanisms by which actually gallium actually can cause apoptosis and cell death. But we have shown that this is actually the case in brain cancer as well as lymphoma. And so these are really, I think, the most important one at this point for our purposes to focus on, just because cancer cells really have this upregulated need for DNA synthesis to overcome any kind of insult provided by radiation therapy or chemotherapy in order to survive. And in case you're wondering, we have shown that this ribonucleotide reductase is upregulated in glioblastomas. It's not present in normal cells, which again shows that any potential normal DNA synthesis that might occur in like low energy cells is not affected by this. It's really targeting the cancer cells because they have this upregulated iron import, and then this target essentially to interfere with DNA synthesis. So we have validated that. We're focusing for this talk on gallium maltolate, which is the newer generation gallium compound compared to the older ones, such as gallium nitrate and citrate, which were previously FDA approved. And we have shown in culture that gallium maltolate is actually more toxic to cancer cells than gallium nitrate. So it is more effective. The positive thing about it is, too, it's not just more effective in killing cancer cells, whether it's lymphoma cells or glioblastoma cells or breast cancer cells, but it can also be given orally because of its formulation. Gallium nitrate is a salt, which meant it had to be given by infusion, a slow infusion over time, which was very burdensome on patients, whereas this can be given orally, which was great for the preclinical studies. It's great for patients, and it also has a high therapeutic index, meaning it's safe to give. We've confirmed this in our rats. We're seeing it in patients where we have some testimonials on their quality of life. And it is yet still effective, which is a great news for us. And this is just to highlight, ever since gallium maltolate was first developed in 2000, this process has been long and arduous, but you can definitely see we have this really positive trend in really building a strong collaborative environment for really developing not just our phase 1 clinical trial, but also going towards the orphan drug status together with Imaging Biometrics, who has really been instrumental in getting us to the point where, we don't just have the orphan drug status, but now we have this open EAP, and we just have this forward momentum going on both ends, not just on the research side, but also on our development side, drug development side, going in tandem, which is just great for us. So just showing you some data now from our glioblastoma cell lines, where different cell lines show that gallium maltolate is highly effective, but it is not affecting our normal endothelial vascular cells that we used as a control. We're also showing high sensitivity to gallium in glioblastoma stem cells. And then just to highlight too, again, the safety of it in terms of it not going into normal tissues. This is an old bone scan showing that using gallium-67, well, not a bone scan, gallium-67 scan showing that it accumulates in high energy organs such as the heart, but then also in the lymph nodes in areas, and case of lymphoma in areas of cancer essentially, but it doesn't really accumulate in any of the normal organs like the lungs here. Again, showing that it is really targeted in where it goes. We're seeing similar sensitivity to gallium in pediatric glioblastoma and the ATRT cell lines. And again, just like with patients responding to chemotherapy, we see different sensitivities among different tumor cell lines, even though they're the same pathology. But what is encouraging, we see similar sensitivity trends in animals as well, which means that our cell culture experiments can actually predict to a certain degree the effect we're going to we can expect in our animal studies. And then just to quickly show too that we have shown that cells are not just cytotoxic in terms of shutting down ribonucleotide reductase, but we're also shutting down energy production and cellular respiration in the cell using this novel seahorse assay in-house, where essentially following a series of inhibitors of cellular respiration, inhibiting the inhibitors, so recovering essentially respiration, and then doing a final inhibition. A series of these steps will show us whether cells can recover their cellular respiration capabilities. And when given gallium, the recovery never reaches baseline compared to control cells that are untreated. So control cells bounce back, they're not affected. Gallium really severely increases that. And then adding metformin into the mix, because metformin also affects mitochondrial complex 1, we have the synergistic effect where these cells really lose all capability of recovering respiration, meaning we have very significant inhibition and shutdown of these processes. And on the animal side, we also see, again, just like we see in the cytotoxicity profiles, we see the same trend of sensitivity when it comes to cellular respiration. So this was our highly sensitive cell line, and this was our glioblastoma cell line. And we see a significant decrease in cellular respiration, which again is great because we're looking at, remember, pediatric glioblastomas are not the same as adult glioblastomas. ATRTs are not gliomas, but we see the same inhibitory and cytotoxic effects across pathologies, which is really great, which means it works in different tumors. Just to show also, additionally, gallium maltolate increases reactive oxygen species production in tumor cells, which causes, again, some toxicity to the cell. And then, so you can see that just again, touching on a couple of mechanisms, there were many more if you're interested. We have several publications out that go through the full gamut of ways by which gallium maltolate exerts its anti-neoplastic effects. But the two really main ones are no DNA synthesis, no energy, cell death. All right, going on to the in vivo work, looking at whether we see what we see with gallium maltolate. And our project, normal kind of project workflows are very simple. We have thymic rats. We inject our tumor cells into the right hemisphere of the brain. They're trained to eat Nutella, which will be our vehicle for the drug. Gallium maltolate is a powder. It mixes well with Nutella, and this way we can actually train the animals to voluntarily ingest gallium. We measure the dose and the consumption before and after, the amount of drug before and after consumption, and then this will give us actually a measure of compliance, because one really important feature of clinical trials is patient compliance. And so while they can't self-report, we can measure how much of the drug they eat, and then that's their compliance. And then we monitor them with our preclinical MRI scanner on a weekly basis. We get conventional and advanced MR images. Previous talks on this webinar series have talked about delta T1 maps and perfusion imaging and in patients, and so we use the same imaging sequences adapted for rats for our purposes. And then we essentially follow these animals until study endpoint and obtain histology from their brains. All right. So first thing I would like to show is that we have, with just gallium monotherapy, 50 milligrams per kilogram per day orally, we have a doubling in median survival. When pooled, it's driven mainly by the males, but we also see a significant survival benefit in females. We don't know if it's inherent differences in iron metabolism between the sexes, or is it because just glioblastomas are different in, they're more aggressive, the incidence is higher in males versus females. Energy metabolism is mainly driven by glucose in males versus females, which is more amino acids in the tumor cells. So we don't know that yet, but this is something in ongoing studies we'd like to tease out, so stay tuned. However, I would like to point out we have a significant survival benefit in adult GBM. We also have that in pediatric ATRT and high-grade glioma, and in all cases, it's really essentially a doubling of the median survival. Granted, the groups are small, but we're in the process of repeating these studies in a larger cohort of animals. But the trends stay true. I'd also like to show, whoops, I don't know what's going on here. As we've shown in culture that the cytotoxic trends stay true from between the different pathologies, we're also seeing an inhibition of tumor growth rate and volume with gallium maltolate monotherapy across different pathologies, whether it's medulloblastoma. This was gallium nitrate, old study, but the trends hold true. Cutaneous T-cell lymphoma, our treatment-resistant adult GBM model, the pediatric ATRT, pediatric high-grade glioma, we have significant reduction in tumor volume over a prolonged period of time. We do see some recurrence after a certain point. And again, we don't know what happens, whether there is a development of resistance, if we're killing off all the sensitive cells and just keep some resistant cells around that drive this tumor progression. We don't know yet at this point. This is also something we're looking at in ongoing studies. And then just to show also that proliferation markers are reduced with gallium therapy, whether it's gallium nitrate or gallium maltolate. In medulloblastoma, our adult GBM model and our ATRT model, not so much in the pediatric model, and we don't know if it's because these are usually less angiogenic, they're more proliferative in nature, or if it's just we didn't have statistical power and we need more animals. So this is something we're looking into also to confirm. But again, we see that we shut down proliferation, which confirms our reduction in tumor volume. We're also seeing a normalization of the vasculature. We see this loss of branching and this chaotic tumor vasculature. We see a straightening of the vasculature following treatment, less branching, uniform lumina. There's usually less staining, less pronounced vasculature available, and indicating we see this kind of return to normal vasculature. We also see a reduction in VEGF expression in our tumor cells and an increase in angiopoietin-2, and this would indicate that there is a blunting or stopping of the tumor angiogenic processes. And this goes hand in hand with a reduction in pro-angiogenic cytokines that has been reported for cutaneous T-cell lymphoma. So again, means that we don't just have cytotoxicity and reduced proliferation across pathologies, we also see an inhibition of angiogenesis across pathologies. And then just to highlight our imaging, we use the same analysis techniques and plugins and programs that we use on the adult side, which have been presented previously using IB Delta Suite. We had this one animal on gallium maltolate monotherapy where the treatment went down from 1 week to the next time point, and we couldn't figure out what was going on. Perfusion was down too, so we euthanized the animal because we thought there was something wrong with the scanner. And histology actually showed a complete resolution of the tumor. No more active tumor cells were seen, which was very exciting. Also showing how we monitor the animals over time, looking at the same time point, day 28 in males, day 36 in females. Treated animals have, again, this much slower development of tumor growth compared to untreated control animals. And again, delta T1 is highly effective in showing us this true enhancement and disruption of the blood-brain barrier. This is an ATRT animal, and you can see we have the capabilities to essentially get this spatially correlated histology going, where we can match the slice on imaging with histology, find the same landmarks, and use this hopefully in the future to gauge more, again, what's going on and confirm what we see on imaging. And this is just an animal. This was an untreated animal with an ATRT xenograft tumor, untreated, progressed to the point where it invaded the contralateral ventricle. And we see some leakage of contrast agent in the CSF. And this was confirmed on histology. This was an animal that had early progression that was on gallium maltolate, and you can see also the tumor progressing in size and kind of some mass effect going towards the contralateral side. And this was a responding animal where the tumor just stayed put. The blood-brain barrier was not very disrupted, which goes hand in hand with our observations that we see this inhibition of angiogenesis, and it was really just sitting there creeping along very slowly, and we had to pull the plug at 6 months because those tumors were just not developing any further, and they were just really sitting in place, stable. And I think that is, if we cannot cure the cancer, I think that is one of the major goals, to at least stabilize the disease. And what's really encouraging is that in our patient population, we see, again, what we see on the pediatric side, this kind of prolonged period until tumor recurs or takes off in growth. We see in the patient population too that progression-free survival significantly extends beyond the historical kind of up to 6 months with when they're not responding to treatment, or even if they're responding, usually within 6 months they will recur. And we see that in our patient population on gallium maltolate, we're exceeding this progression, time to progression, just like we see on the animal side, which is encouraging, greatly encouraging, because what we see in culture, we can predict in terms of response on the animal side, and we can now hopefully use this also to predict on the patient side, because the trends are holding true, truly in a translational manner from culture to animal to patient. We see the same trends, we see the same responses between responders and non-responders, which is highly encouraging that we are on the right track. Now, I mentioned patient testimonials. Our animals are doing great. They are in much better body condition when we have to euthanize them versus the untreated animals. And we see this quality of life benefit in patients also. And this is something Dr. Conley likes to show. Patient that mentioned, I don't feel sick. I'm concerned that I don't feel sick. I don't feel like a cancer patient. My husband is concerned that I'm not experiencing symptoms and feeling sick. My husband is very concerned and worried about me, but I do not feel sick. So we definitely have a quality of life benefit in addition to this tumor inhibition. Now, just before I finish, I want to show, I'm really excited because we have some evidence that I would like to share that gallium maltolate may actually act as a radiosensitizer, which could completely open up our capabilities in treating patients that have really no treatment options, especially since radiation is part of virtually every treatment plan on the pediatric side, especially, but also on adults. Ionizing radiation works by essentially damaging DNA directly, but also by producing reactive oxygen species. Now, I've mentioned earlier, gallium maltolate increases reactive oxygen species production, which could potentially exacerbate the amount of insult that radiation can do to DNA, cancer cell DNA, but we also know that it inhibits DNA repair, which is probably the primary way by which gallium might benefit, give this boost to radiation therapy. Now, in culture, we're showing that compared to to radiation therapy and gallium maltolate therapy alone, combining the two, we almost have a 50% loss in viability in just conventional U87 cells. And even in the treatment-resistant glioblastoma cells we use, if we pre-treat with gallium maltolate, radiation therapy seems to have a much greater cytotoxic effect than if we just give gallium maltolate therapy alone. So we have here on campus a small animal radiation, a precision radiation machine, which allows for radiation planning, just like in the clinic. And we irradiated an animal with half the clinical dose. We gave 21, about half the clinical dose. Treatment protocols vary, obviously. It had an adult treatment-resistant glioblastoma implanted in its brain. We gave 3 doses of 7 gray each, so a total of 21 gray. And we monitored with imaging. I gave some bevacizumab while the tumor was increasing to keep the radiation necrosis in check. And as you can see that after peaking around the same time, we have to euthanize our gallium maltolate rats because the tumors just grow so big. We saw a significant shrinkage in tumor growth in the gallium plus radiation treated rat. And this lesion increase, we've seen it before with monotherapy. It's really just cell swelling, cytotoxic cell swelling, just like what we see with radiation therapy. So that's why we see this lesion expansion happen. And this is not updated. This animal lived to day 245. But we see that combination therapy, radiation, and gallium maltolate quadrupled the survival essentially of our gallium monotherapy rats, and more than quadrupled essentially the survival of radiation only rats from a previous project. So obviously we're going to repeat this. Just very lastly, we have the capability now to monitor treatment effect with MR spectroscopy during our imaging, preclinical imaging. And we can longitudinally monitor treatment effect now. And we're showing that in our gallium maltolate treated and radiation treated rat, we see this disappearance of the choline to creatine peaks, which is our tumor marker over time. This is day 44 is our radiation therapy baseline after the rat was on gallium maltolate for a month. And we see this peak disappearing and the vinyl and lactate peaks just going up, which is necrosis. This has really continued up until like day 177. Vinyl peak, apoptosis peaks up, choline creatine ratio peaks just disappearing. So we have evidence of treatment effect. And this was then confirmed. Thank you very much to Melissa Pra, an engineer in our lab, who has presented previously on fractional tumor burden maps in this webinar series, where we are able to look at tumor necrosis and tumor and kind of this transition period. Imaging biomarker, and the fractional tumor burden maps really really confirmed what we're seeing with the MR spectroscopy, that we see this just huge necrotic area building. And by day 105, you see there's really the majority of tumor is really just necrosis. There are a few spots where there might be some tumor. And once the rat was taken off gallium maltolate and left for another 6 weeks and monitored, it did develop neurological signs and had to be euthanized, which just shows that we didn't kill the entire tumor, and it's possible we used a only a half a centimeter collimator, and we might need a bigger one to get some of the external area treated too. But it seems to indicate that if we had continued gallium maltolate, this rat might have just kept going because we would have kept the tumor in check and stable. But this is something now we're going to, this study we're going to repeat in some more animals this spring. And so we'll hopefully have some more answers. But what this indicates is that pretreatment with gallium maltolate, followed by even just a half a dose of radiation therapy, seems to be highly effective in not just killing the majority of the tumor, at least in this animal, and maintaining this for quite a while. And then I'm not going to go into this, but we are very encouraged by some of our preclinical cell culture data that we see quite some cytotoxicity in different breast cancer cell lines. And because breast cancer and brain cancer actually share a lot of the same iron import, export, and iron regulating proteins, we are conducting some studies now and hopefully moving on to animal studies by the end of the year, looking at breast cancer and breast cancer brain metastases and see how gallium maltolate how effective it is in vivo in these cell lines, because that is a project we would like to get going at one point, not just on the animal side, but the patient side too, looking at expanding the use of gallium maltolate to patients with brain metastases, not just breast cancer. Because once patients develop brain metastases, usually survival is only another year or so. So we're kind of hoping that we can expand the use to that patient population in the near future. And I'm going to end here. And if you have any questions, I'm ready to go.
Thank you very much, Dr. Al-Jazawi. Let's open it up for questions, and it looks like we have one here. It says, how does 240 plus days in a rat translate to humans with respect to overall survival?
Years. I don't have the exact number, but it's years. There is a formula. There are some papers out, but usually a week will translate to months. And then we're looking here at months already, so we're looking at years, translating that to patients. Potentially, right? Potentially.
Thank you. And then from Dr. Mazzella, have you tried GaM during radiation in GBM patients?
No, that is planned for our phase 2 clinical trial. This is, like I said, this is hot off the press. This is really, I just finished this January 1st, this project, the data for this rat.
Okay, another question. Would the expanded access program allow use during radiation?
It should, I think. That might be a question for Dr. Shitamba or Dr. Conley, but I think it should allow for that.
Okay, and a comment here. A quick online search says 13.7 rat days equals 1 human year. Thus, 240 rat days equals 17.5 human years. That's quite a long time.
Yeah, I wouldn't probably go that far, but yeah, I mean, years. And I think for a patient with glioblastoma that has only, a survival outlook for a couple of years, like glioblastoma is a terminal cancer, regardless what we throw at it. To add even just, another 3 or 5 years with great quality of life, I mean, that's already a bonus. And on the pediatric side, what I didn't mention, those pediatric patients with ATRT, those are like, 2-year-old kids that don't have a long life expectancy, a couple years maybe. They rarely make it past 5. Highly burdensome, highly toxic treatments, really poor quality of life. And so just adding some more years with a better quality of life, again, that's a win in my book. So I wouldn't focus too much on the numbers or like how much. I think what we need to focus on is that I think the quality of life component is, I think for most cancer patients, that sometimes outweighs for how long they're going to survive. But if we can, on top of that, add years, maybe not 17 years, I'm not sure that's a long-term study. We're not set up for that. But if we can add several years to that, then I think, yeah, we're halfway there, right? We can't cure it maybe, but we can keep it at bay.
Yes, okay. Dr. Sengupta has a few questions, so I'm going to start with the first one. Have formal quality of life metrics been tested, and is there an intent to do this in the phase 2 trial?
So not in the animals. In the animals, I use body condition, body weight, which is typically on an increasing trend over time. They don't lose body weight. Towards the end, they're also cognitively, the rats are in much better shape, activity-wise, body condition-wise. We haven't done any behavioral studies yet. That's something I would really like to explore, to look at any differences in, or changes in cognitive behavior activity. And then on the patient side, I don't know, I'm not sure how much other than beyond like a KPS score would be incorporated on the phase 2 trial. But I know there are some basic metrics in place, but I don't think it's a big component in terms of like special research component at this time.
Okay. And in terms of stable tumors, can you elaborate what tumor types is this regardless of molecular profile?
So the best we've seen right now was an ATRT. Granted, we tested the cell line that was most sensitive in culture, but we've seen this kind of trend even in the glioblastomas, both adult and pediatric, where we just see this kind of plateauing of the tumor volume where it doesn't change for a few weeks. And then it tends to take off, and we don't know what happens at that point where it just changes in growth, where it just sits there and then suddenly decides to change. We don't know yet what's happening there. Hopefully that's something we can explore with some upcoming grants. Because once we figure out what makes the tumor take off after responding for quite a while, I think then we have options. It gives us an opening to then use either secondary treatments, change our dose, maybe we'll have to give it twice a day instead of once a day, stuff like that. And so we need to first understand what's happening, what really keeps it in check. It's possible that we're inducing some kind of senescence and just make some of the cells dormant rather than killing them. But at this point, we don't exactly know really what keeps it stable. That's definitely a big knowledge gap.
Okay, and a third part of her question, iron in cancer cells can be dictated by nutritional intake. Any thoughts of looking at diet as a data point?
We just, in our, just the grant we submitted this January, we actually, one of the aims in the animal portion of the protocol is to look at low and high iron diets compared to standard iron diet and see how that affects sensitivity to gallium therapy. So we've proposed it, we haven't tried it yet. Cell culture indicates that if you have higher iron environment in the tumor cells, then usually gallium is kind of outmaneuvered a little bit, and the cells are they're less sensitive because there's more iron to kind of counteract that. But we don't know in vivo, we don't know yet. But we have proposed it and we're planning to look at it.
Okay, very good. And she comments there might be a way at looking at system XC.
I'm sorry, I didn't catch that last portion.
Let me see if I can allow her. Okay, Dr. Sengupta, do you want to go ahead and ask Dr. Al-Jazawi yourself?
Yeah, my suggestion is rather than just looking at iron, you might want to look at system XC, which is the transporter that moves cysteine and glutamate, because that basically is contingent on iron. And you can have diets that are linked to iron metabolism and ferroptosis, which might enhance the activity of gallium maltolate.
Oh, interesting.
And
Yeah, well,
the person I would recommend that you collaborate for that is actually here at UNC.
okay.
He's going to be having a nutrition study that opens up, looking at the System XC transporter. So you might be able to collaborate with him on that.
All right, that sounds great.
Thank you, Dr. Sengupta.
You're welcome.
It looks like that is the end of our questions. So we think this concludes the meeting for today. This will be recorded and made available. If anybody has questions for Dr. Al-Jazawi or would like to help me facilitate connecting anyone, please just go ahead and email me at eap@imagingbiometrics.com. And again, thank you very much, Dr. Al-Jazawi, and thank you everybody for joining us. And please look forward to future webinar invites. Have a great day.
Well, thanks for having me.